No gender preferences here. Due to the quantitative or qualitative deficiencies of von Willebrand factor found on chromosome 12, the symptoms are similar to a platelet function defects like epistaxis, easy bruising, bleeding, menorrhagia. The clinical features are, as a general rule, in the coagulation, type 1 deficiencies refer to a decrease in the absolute amount of normal factor, and type 2 deficiencies indicate a defective protein that may be present in normal amount. Type 1 is 70 to 80%. Most common autosomal dominant, partial quantitative deficiency of the factor but normal function. It causes mild to moderate bleeding disorders and platelet count is normal here. In type 2, which is 15 to 20%, there is qualitative deficiency of von Willebrand factor. There is variable quantitative deficiency, usually mild to moderate bleeding disorders, but may be severe. Type 2A, it is most common type 2 subtype. It is autosomal dominant. There is low to normal factor VIII activity as well as von Willebrand factor, and the platelet count is here normal. In type 2B, which is autosomal dominant, the platelet count drops further during pregnancy and surgery. They have low to normal factor VIII activity and von Willebrand factor activity. In type 2C, which is autosomal recessive, and it is rare. Type 3 is very rare, autosomal recessive in nature, and the most severe clinical bleeding occurs here. Another rare type is platelet type or pseudo von Willebrand disease, rare disorders of mutation in the GP1B causing increased binding of von Willebrand factor to GP1B with similar clinical findings as type 2B. The diagnosis: testing factor VIII activity, von Willebrand factor antigen, von Willebrand factor itself, and the possible additional tests include von Willebrand factor multimer size determination and blood type, because this factor is significantly decreased in type O patients. The repeat testing is often required because this factor VWF and the factor VIII, they become elevated during minor illness, during injury, stress, pregnancy, with the use of estrogen or other acute phase reactions, and as well as in newborns. Now the transfusion. Principles of transfusion. Blood is transfused. So before the transfusion, select the healthy blood donor with hemoglobin should be 12.5 grams per deciliter. Blood collection by phlebotomy in a sterile anticoagulant containing plastic blood bag with anticoagulant which is used is acid citrate. The storage of blood bag in refrigerator at 2 to 6 degrees Celsius. The donor testing for ABORH grouping and for infectious organisms like hepatitis B virus, hepatitis B surface antigens, hepatitis C virus, HIV, syphilis, and malaria. Blood grouping, ABORH of the recipient also. Pre-transfusion compatibility testing of donor and recipient. Number 1, antibody screening of the patient's serum to detect the presence of clinically significant antibodies. Second thing, cross-matching the patient's serum against donor's red cell to confirm donor-recipient compatibility, and then the supervision of the blood transfusion to observe the reaction, if any. The transfusion reactions. Transfusion reactions could be either immediate or delayed. There is rapid cell destruction associated with intravascular hemolysis, and it is usually due to ABO incompatibility. since both naturally occurring antibodies, anti-A and anti-B, these are capable of fixing complement. The symptoms include restlessness, anxiety, flushing, chest or lumbar pain, tachypnea, tachycardia, and nausea, and it could be followed by shock and renal failure if left untreated. Extravascular hemolysis more often due to immune antibodies of the Rh system, and the clinical manifestations are relatively less severe and usually consist of malaise and fever, and shock. Renal failure may rarely occur. In delayed type of reaction, anemia due to destruction of red cells in the Re system about a week after transfusion can occur, and such delayed reactions are generally the result of transfusion. The allergic type of reaction are most common type of transfusion reaction, usually mild, but can range from simple urticarial reactions to life-threatening anaphylaxis. The symptoms generally starts within minute of transfusion onset, but can occur up to 4 hours after transfusion. Allergic transfusion reactions are common and generally mild, presenting as urticaria and pruritus. For a mild allergic reaction, transfusion can be paused, the patient given appropriate medication, and if the symptoms resolve completely, transfusion may continue with observation. This is the only transfusion reaction that does not require a complete stop of the transfusion. The type 1 immediate hypersensitivity reaction. B cells produces immunoglobulin E antibodies in response to allergens, the plasma proteins, and these antibodies bind, causing basophil and mast cells activation and degranulation, and resulting in the type 1 or immediate hypersensitivity reaction. The clinical presentation: mild allergic reaction to severe anaphylactic reactions. Mild allergic reactions include urticaria, flushing, pruritus, mild localized angioedema, and the severe anaphylactic reactions include allergic symptoms plus hypotension, dyspnea with or without signs of airway obstruction, angioedema, abdominal pain, vomiting, and loss of consciousness, finally shock. The complications of transfusion: there is circulatory overload resulting in the pulmonary congestion and acute heart failure and the death following transfusion. The risk of overload is higher in the patients with chronic anemia, in infants, and the old age persons. Massive transfusion can lead to the development of dilutional thrombocytopenia and dilution of coagulation factors as well. Transmission of infections like hepatitis B virus, C virus, cytomegalovirus infections, syphilis, malaria, brucellosis, AIDS, HIV. Risk is greater in those suffering from hemophilia, thalassemia major, and acute leukemia, because these patients, they required frequent transfusions. Thrombophlebitis associated with venesection for the blood transfusion done in the saphenous vein of the ankle, and if the duration is more than 12 hours at single site. Post-transfusion iron overload or hemosiderosis. It is also occurs in the patient with repeated transfusions. DIC, disseminated intravascular coagulation. This one is an acute, subacute, or chronic thrombohemorrhagic disorders, and it is characterized by excessive activation of coagulation, which can lead to the formation of thrombi in the microvasculature of the body. Epidemiology of the disease. 1% is occur in the hospitalized patients. 20% of the patients 20% of the disease occurs in patients with acute respiratory distress syndrome, and the 20% of the patients with DIC can develop ARDS. 20% of the patients with gram-negative sepsis develop DIC. Infection or sepsis like bacterial, viral, fungal, rickettsial, protozoal organisms. I have already told you the tissue damage, trauma, burns, and malignancy. These all can predispose to the DIC. The obstetric complications, abruptio placenta, retained dead fetus syndrome, preeclampsia, eclampsia, amniotic fluid embolism, acute fatty liver of pregnancy, septic abortion. These all are predisposing factors or obstetric complications. Miscellaneous near to drowning, fat embolism, snake bite, aortic aneurysm, acute hemolytic transfusion reaction, adult respiratory distress syndrome, giant hemangioma, homozygous protein C deficiency. These all are etiological factors. Pathophysiology, shortly, DIC is characterized by massive, sustained, and excessive activation of coagulation with eventual overwhelming of the anticoagulant and fibrinolytic system, and leads to the disseminated microthrombi and tissue ischemia. Consumption of platelets, coagulation factors, natural anticoagulants, and there is variable bleeding. Activation of the inflammatory pathways also occurs via the cytokines, which are also playing important role. Ultimately, the free circulating unopposed thrombin and plasmins are generated, which then lead to the activation of Ada Salim internet connection calling. Ada Salim. Connection internet जो connection खत्म थी वो
connected है
क्या है Okay, beta, activation and consumption of platelets, coagulation factors, fibrinogen and fibrin, and the consumption and depletion of anticoagulant proteins like protein C, S, and antithrombin. Generation of D-dimers, fibrin degradation products, formation of microthrombi, which are leading to the tissue ischemia. Large thrombi can also be formed, and particularly in the cancer patients. Schistiocytes, the fragmented RBCs, these are formed as red blood cells are served flowing through fibrin strands. Microthrombi within the vasculature and variable amount of bleeding is there. Clinical presentation, there is bleeding or thrombosis or both. Septic patients are more likely to have thrombosis than bleeding, and if severe and prolonged will lead to multi-organ dysfunction or failure. Causes of DIC can be acute or chronic, localized or systemic. Chronic causes are malignancy, liver disease, retained dead fetus products, abdominal aortic aneurysm, giant hemangiomas, and head trauma. Bleeding can be at the surgical site, venipuncture site, or mucocutaneous, which is most common. Gastrointestinal, CNS bleeding, hematuria, ecchymosis, cold, pulseless limbs, sudden loss of vision, oliguria, mental status changes, seizures, behavioral changes, or adrenal insufficiency. These all are the clinical presentations. The laboratory findings here are prolonged PT and PTT, elevated D-dimers, other fibrin degradation products, decreased platelet count but not lower than 30,000, drop in fibrinogen, presence of schistiocyte, but these are not specific for DIC. With chronic causes, there is fibrinogen and platelet may actually elevated as an acute phase reactants. All coagulation factors are decreased and there is elevated cardiac enzymes or elevated blood urea nitrogen, and creatinine. Morphology commonly affected organisms are initially brain, then heart, then lungs, then kidneys, adrenal, spleen, finally liver. Kidney. Small thrombi into the glomeruli causing reactive swelling of the endothelial cell. In severe cases, microinfarcts or bilateral renal cortical necrosis. In lung, fibrin thrombi in alveolar capillaries causing pulmonary edema and fibrin exudate. In central nervous system, microinfarcts resulting from fibrin thrombi complicated by massive hemorrhages leading to the neurologic deficits. Adrenal fibrin thrombi causing massive hemorrhage leading to the Waterhouse-Fredrickson syndrome and Sheehan syndrome in pituitary glands. Thank you so much, beta. Any question?